Okay, we're going to get started now. Hello, everybody. Welcome. Thank you for joining this installment of our congressional briefing series on protecting federal leadership in addiction science and public health. This is the fifth briefing in a series. My name is Diana Fishbein, otherwise known as Denny. I'm at the University of North Carolina in Chapel Hill. In the Child Development Institute. I'm also a part-time position at Penn State, and I'm the director of the National Prevention Science Coalition to Improve Lives. So this briefing, this fifth briefing focuses on the role of community engagement in reducing substance use and promoting community well-being. Substance use affects communities in all sorts of different ways. And so effectively responding to it has to be rooted in the realities and the strengths and needs of those communities. Research consistently shows that lasting progress depends not only on strong science, but also on the meaningful partnerships that can be developed between researchers and the people who are most affected. So today's discussion is going to highlight that community engagement is not just an add-on to prevention, treatment, and recovery. It's really central to their success. When communities are actively involved, programs are more relevant, they're more trusted by the community, and they're much more likely to be sustained over time. So this session brings together research, evaluation, and lived experience to examine what we know about evidence-based community approaches. Our speakers are going to talk about how community-informed strategies help ensure that policies and interventions are culturally responsive and practical in real-world settings. They'll be sharing insights on how community engagement strengthens implementation and improves outcomes ultimately, and helps to translate the research into action, bring it to life. So they'll explore also how collaboration across sectors can support healthier communities and more effective substance use responses. These are the briefing sponsors, the National Prevention Science Coalition to Improve Lives, which is a large professional organization devoted to systematically translating the body of evidence from prevention science to public health policy. And also the Addiction Science Defense Network, which was developed about a year and a half ago, last February 2025, to preserve funding for research and the evidence-based programs that are so critically needed. We formed the ASDN so we can provide an action network for individuals and organizations that study, treat, and prevent problems that are caused by psychoactive substance use and other addictive behaviors. And our network is very broad. It includes research societies and addiction journal editors and practitioner organizations and programs that are engaged in the training of scientists and clinicians and other organizations that overlap with the addiction science community, as well as individuals with lived experience. So what we're doing is advocating in Congress and with federal agencies to preserve funding for the research that is truly foundational to our nation's response to substance use crises. We are also urging that the federal government reinstate and scale up supports for states and communities to be able to reliably deliver needed programs and services. And we're informing the public so that they also understand the importance of urging the representatives to preserve this infrastructure, which is truly life-saving. So first, three announcements. The Addiction Science Under Siege report that we orchestrated was released on May 7th when we had a very well-attended webinar with media coverage. This report presents findings from an in-depth analysis by the ASDN members of how federal actions have tangibly impacted infrastructure that supports treatment, research, and prevention services. So if you have a chance to scan this, great. If not, we will be putting the link in the chat so that you can look at the report, you can endorse it for letters to Congress, and you can support it in a number of ways. Secondly, and very importantly and very urgently, the Office of Management and Budget, through Russell Vogt, has recently announced their playbook to dismantle research at the federal level. There are implications that you can see here that are just summarized on this slide. There's much more involved here, but there are implications for grant award decisions that will be based on political priorities rather than merit. There will be restrictions in travel, in publishing, in doing work related to DEI, types of training programs, and the potential for active grant awards that were already awarded to be terminated at any time. So rather than going into a lot of detail about that, I'd urge you to contact us for more information and suggestions for how to respond to the Office of Management and Budget. Every response by law must be responded to by them. So it's very important that we have thousands of people that are writing to express their opposition to this change in the rules. I also want to announce our sixth briefing, which we are going to have on September 15th, that's going to feature one speaker because I believe so strongly in the work that she has been doing throughout Canada, especially the Alberta province, as well as some of the states here in the United States. Nancy Mannix, she is a powerhouse, and we're calling this a whole of society approach to substance use, and see this as a real culmination of all the briefings that we have put on to date. So with respect to speakers, we have Joshua Gales, Assistant Research Professor at the Edna Bennett Pierce Prevention Research Center at Penn State University. And she's going to kick us off with centering community power and wisdom to prevent substance use and promote youth well-being. And here are other speakers. Okay, here are other speakers. Sorry, I couldn't see it. Here are other speakers. They will be introduced as they speak. Please see the website for their full bios, because if we were to read all their bios, it would take up the entire hour and a half. They're all very accomplished. So we're really excited to have them. And just a few housekeeping tips. Feel free to message each other in the chat. Creates a sense of community. You can all introduce yourselves and have any kind of exchange that you would like. We do look at the chat later to see if there are any important resources or information that we want to add to the website. So feel free to do that. But if you have questions for the speakers, add them to the Q&A box nowhere else, and the speakers will track them as we go along during this briefing, and we will have about a half an hour at the end to address questions verbally. Everything will appear on the website a week or two after the briefing is over, and you will automatically receive a link to slides, the recording, and resources. So now I want to introduce Holly Chapman, who is an intern with us. She's a PhD in translational medicine with a specialization in neuroscience and behavior of addiction. She has participated in preclinical, clinical, and policy research on addiction-related topics, as well as provided education on opioid overdose and medication-assisted reversal. She's interested in substance use and mental health policy as an avenue to reduce stigma and improve state laws around people who use drugs. So she is going to introduce each speaker, but I already introduced Joshie Gales, so we're going to begin with her, and then Holly will join us to introduce the rest of the speakers. Thank you very much. Joshie?
Thank you, Denny. Am I able to share now? Okay.
Yes.
All right. You guys see that okay?
Yes, we see the slides.
Okay, perfect. Thank you so much. And thank you, Denny, for the introduction. And thank you, members and staff and folks who are joining today. So my work lives in a specific place It's really the space between rigorous prevention science and the real communities where that science has to actually work. So my message today is really captured in one phrase. We have to center community power and wisdom to effectively prevent substance use and promote youth well-being. And by that, I mean something concrete. The people that are closest to substance use, our youth, our families, our local leaders, they don't just need our programs. They hold the knowledge that our science depends on. And when we treat communities as partners with wisdom, not just as recipients of programs, prevention works better and it lasts longer. Now, you may have heard across this series that prevention science delivers, and the evidence is striking. Adolescent substance use is now at an all-time historic low. In the most recent national data, we see that roughly 91% of 8th graders, 82% of 10th graders, about 66% of 12th graders have abstained from alcohol, marijuana, and nicotine in the past month. And overdose deaths have fell nearly 27% in a single year. And I would say that these are not just accidents, they are the return on decades of federal investment. So my goal in the next few minutes is to really talk to you about how community power and wisdom turns that science into real results and what it takes from our federal government to keep it going. So the central thing here is that a proven program, which we have a lot of, is not the same as a working program. We can hand a community the best evidence-based curriculum in the world, and it will fail if there's no local capacity to deliver it well, no data systems to know if it's working, and no trusted relationships to bring those families in the door, and if the program does not fit the context of that local community. This is what we've seen time and time again in our work. Now, the program is the seed, but what we're arguing is that the infrastructure is the soil. And right now, federal investment overwhelmingly funds seeds while underfunding the soil. So I'll tell you how this relates to community wisdom and power. But first, let me explain what do I mean by infrastructure. There's three concrete things to think about here. People and local capacity. These are your coalitions, your coordinators, your trained staff. The data and evaluation systems so that communities can see what's working and adjust in real time. And the technical assistance and training needed to support and the capacity building that helps the community deliver a program with fidelity and sustain it. Now, this is all the unglamorous part of prevention. It doesn't make the headlines, but it is the difference between a grant or a project or program that produces a binder that sits on a shelf to collect dust and one that can transform a whole town. And the core idea behind this comes from our very own research, my team and I at Penn State, where we've seen that the most successful community prevention efforts do one thing well. They combine community wisdom with research-based practice. Not one or the other, both. The science gives us what is proven to work, and the community gives us what will actually work here, in this neighborhood, with this history, for these families. But here's what I think is most important to understand and what I've been coming to learn over the past couple of years. Community power and wisdom don't just show up on their own. They have to be supported. A community can't co-lead a prevention if there's no coordinator to convene them, no data they can see and trust, and no trained local staff to carry the work forward. That support has a name, and it's called infrastructure. So these two ideas, community wisdom and infrastructure, they are not in tension. Infrastructure is what makes community power and wisdom possible. It's the soil that lets the community wisdom take root and grow into lasting change. And this is exactly what the National Academies concluded last year. Their blueprint found that our prevention system is insufficiently funded and fragmented. And they called on Congress, NIH, CDC, SAMHSA to sustain the workforce, the data systems, and the community supports that prevention depends on. So the nation's top scientific body is saying what communities have been telling us for years. Fund the infrastructure and you unlocked the community wisdom at scale. So I can provide some examples from our very own work. Through the Evidence to Success initiative that is supported by the Annie E. Casey Foundation, we've spent over more than a decade partnering with 6 communities across the country to put prevention science and practice with residents, not at them. And the pattern has become very clear. Prevention, when community wisdom and expertise is centered, works. In one of our communities, they used the structured, data-driven approach to focus on the risk and protective factors that they identified, like family attachment, school connection, access to healthcare. And then they chose evidence-based programs that fit their context and made adaptations when necessary. The result, in their words, was not just better youth outcomes, but a foundation for lasting community resilience. So why does this work, or why did it work for these communities? Because when communities help interpret their own data and choose their own priorities, we change whose voice is heard. We change what gets prioritized and how resources are spent. That's community power. And the programs that come out of it are trusted, used, and sustained, which is where the return on investment actually comes from. But none of that happens by accident. It happened because there was infrastructure. There was a coalition, a coordinator, a data system, and ongoing technical assistance and support. And when that scaffolding is there, community wisdom has somewhere to live. When it disappears, the work unravels, no matter how good the original program or vision was. So in some current work that I'm beginning, I currently hold a fellowship inside a formal research practice partnership between a university and state agency here in Pennsylvania. And the partnership is built not to just produce research and hope someone uses it. It brings the people who make decisions, the policymakers, the practitioners, the communities, and the youth with lived experience. In this particular fellowship, it's with youth with foster care experience, but it brings them directly into the research itself as co-designers. That is the infrastructure of community power and wisdom that is built right into how the decisions are getting made. And so what I hope is clear here, and from this work and the previous work, is that partnerships are being funded where community wisdom and community voice is being elevated and being highlighted, and they're being funded today by philanthropy. So foundations are already seeing the value of connecting research to practice and community, and we need our federal government to see it too. And I believe that while philanthropy can seed these models, only sustained federal investment can scale them to every state and every district. So why does this require federal leadership, one may ask? And I say because community infrastructure cannot be built one short grant at a time. Coalitions, data systems, and trained local staff take years to build, and they collapse when funding is unstable. And the economics are extremely overwhelming. In some school-based programs, prevention returns as much as $25 for every dollar invested. And over $1,000 in future health costs are saved for every dollar spent on tobacco prevention. So we can see that prevention is one of the highest return investments that the government makes, but only when it's delivered well. And community wisdom supported by infrastructure is what makes it delivered well. When we cut the agencies that build this capacity, we don't just cut research. We cut the connective tissue that lets every community and every district turn evidence into local results. So my ask, or my statement here is, if we want to prevent substance use and promote well-being, we need to center community wisdom. This is what works for sustainability, to make a program fit, to have families show up, And to do this, we need to fund the infrastructure that makes it possible. I think that this can be done concretely through three things. Protect the federal agencies that build the local prevention capacity. They really are the backbone of this system. We need to fund durable supports, not just the one-off programs, but the coalitions, the coordinators, the data and technical assistance systems that let communities lead. And we need to invest in community engagement as a core infrastructure by including the voices of the youth, the families, and those closest to the challenges that we're trying to prevent. This is not an add-on or an afterthought. It really is the active ingredient. And I want to close by saying we are at a rare moment. Youth substance use is at a historic low, and overdose deaths are falling. So we are winning for the first time in a long time. And this really is exactly the wrong moment to pull back. The science is proven, and the wisdom really is in our communities, and they are ready. So we need to invest in the soil so the seeds that we've spent decades developing can really take root everywhere. And that infrastructure as the soil. So if we can fund that infrastructure that really gives that community wisdom, the power and the movement to grow, it will take root and grow in every district across our nation. So I will stop there, and I believe my other presenters have some great and more specific examples about how this work really shows up. Thank you so much for your time, and I look forward to your questions.
Yeah,
You're
I
up.
can't turn on my video, but I can turn on my audio. So we'll move on to the next presentation. Thank you, Dr. Gales. So the next presenter, oh, there we go. Perfect. The next presenter is going to be Mike Marshall. He is the Chief Executive Officer of the U.S. Alcohol Policy Alliance and co-founder of Oregon Recovers and OregonRecoveryNetwork.org. He brings more than 30 years of change-making, policy, advocacy, and civic organizing experience to this role. His talk is titled Alcohol, a National Crisis Hiding in Plain Sight. Take it away, Dr. Marshall. Or, I'm sorry, Mr. Marshall.
Sorry about that. I was trying to figure out how to turn my microphone off. Thank you very, very much, everyone, for inviting me here. Can you see my screen?
Yes.
Yes.
Great. Okay. Uh, Really wonderful to be with all of you. And thank you, Denny, and the National Prevention Science Coalition and the Addiction Science Defense Network, and all of you for being here. And I'm still getting my head around that just wonderful presentation we just received about the importance of wisdom and power in the community work that we're doing. And so I'm going to start off by saying that in huge part of, or from my perspective, an critical part of wisdom and power is knowledge. And I'm here to talk about alcohol, and what I found in the course of doing the work that I'm doing with the U.S. Alcohol Policy Alliance is it's not just a matter of educating people about alcohol. It's a matter of re-educating them about alcohol. And so that's where I'm going to sort of start today with folks. It's There we go. I'm the co-founder of Oregon Recovers. I'm 18 years in recovery, which is my, instead of having a PhD after my name, I'm very proud of the fact I have no conflicts to report. The U.S. Alcohol Policy Alliance, our mission is to translate alcohol policy research into public health practice to prevent and reduce alcohol-related harms. And it's not just about alcohol use disorder, but it's all the things that contribute to alcohol use disorder, and as well as the harms that the much broader set of harms that alcohol creates in as a consequence of the fact that we don't think of it as a toxic, addictive carcinogen that should be regulated at the same level as tobacco or other substances that are harmful. We are really the only national organization exclusively focused on reducing the harms around alcohol. That doesn't mean that there aren't other good organizations focused on alcohol policy work, but we are a lone voice up against about 300 lobbyists from the alcohol industry and $5 billion in annual advertising by the alcohol industry promoting alcohol consumption. USAPA, that's our acronym, the U.S. Alcohol Policy Alliance. USAPA, we are comprised of officially of 12 different state community coalitions that we work closely with. There's probably another 10 states where there are either statewide or large local coalitions that we work with as well. So our work is very much driven at the community level, recognizing that so much of the alcohol policy is decided at both the local and the state level for a whole variety of reasons. I just wanted to bring forward this headline from Stat Magazine from last month. They released a 4-part series that is really, really good, and I would suggest everyone peruse it if you're interested in understanding alcohol. But this headline sort of captures, I think, or instills the notion that we're not dealing with the very substances at the root cause of so many of this country's challenges, and that is really devastating our communities in a way that is sort of hiding in plain sight. I often paraphrase this, but now that it's in print, it's a really important way to be thinking about alcohol. And we also need to acknowledge from the outset that alcohol is a unique substance, right? It's mentioned 258 times, I think, in the Bible, and it's an integral part of so many aspects of our society. Whether it's a baby shower, running a race, there was under the Biden administration, there was Get a Shot and Get a Beer program where alcohol, if you got vaccinated for COVID, you got a free beer. And despite the fact that COVID was a respiratory virus and that alcohol undermines the respiratory system and as well as the judgment system, our president owns two. He does not drink, and he's very forceful in his concerns about people who do drink. And yet he owns two alcohol producing companies. So when talking about community-based solutions and orienting people towards addressing our alcohol problem, we need to be really clear about, unlike other substances, how deeply integrated it is into our communities and honestly into our families. And I say that as someone who comes from an Irish Catholic family that drank when they were happy, drank when they were sad, drank if it was on Tuesday. I don't think we were unique or unusual in that regard.
Mike,
Hi,
I'm
Mike.
terribly sorry to interrupt, but your
Yeah.
slides are not advancing. Excellent.
Okay, apologies. So this
No
was the
problem.
headline from Stat Magazine that was, I think, very powerful. This is a representation of how integrated alcohol is into our communities and into our families, as I said. The good news here is that alcohol drinking is at an all-time low. According to the Gallup poll, which has been measuring this since right after Prohibition, only 54% of Americans drink, which means 46% of Americans do not drink. That is tremendous news and something that should be celebrated and acknowledged. Women drink less than men. White Americans and more affluent Americans drink more than people of color and less affluent Americans. But again, the underlying message here is that almost half of Americans don't drink alcohol, and I think that's huge progress. But the downside is that the harms related to alcohol are more higher than before. 10% of Americans 12 and older have an alcohol use disorder. Over 5% of youth, so that's 12 to 20, have an alcohol use disorder, and binge drinking. 1 in 5 Americans engage in binge drinking. And it's those last two core categories where we see the most harms created. And in fact, it's also where we can have the best community solutions to try and address it. And so in the last 10 years, we've seen a 30% increase in alcohol-related deaths. This is against the backdrop of fewer people drinking than ever before, and yet a dramatic increase in alcohol deaths. And think about how many headlines have you seen relative to this? How many community initiatives have been brought forward? How much policy has been focused on reducing the alcohol-related fatalities? Over 178,000 Americans die each year. Comparatively, I think we're right at about 110,000 opioid overdose deaths. That's almost 500 Americans each day. And the real thing that's important to recognize is that despite the fact that affluent white Americans drink more than people of color or queer people in general or low-income folks, marginalized communities disproportionately are represented both in alcohol-related fatalities as well as emergency room visits and hospitalizations, which are also up at unprecedented levels. So we have a situation here where the number of Americans are drinking less, but the folks that are drinking are experiencing significantly more harm. And it's not just alcohol use disorder, it's the things that often contribute to people developing an alcohol use disorder or addiction. 1 in 3 suicides involve alcohol. 40% of gun violence perpetrators and or their victims have alcohol in their system. 40 to 60% of domestic violence, depending on which studies you look like. 15% of opioid overdose deaths involve alcohol. 5% of new cancer diagnoses, so about 25,000 cancer deaths each year, are from a direct consequence of someone's alcohol consumption. It doesn't mean that they're have an alcohol use disorder. It doesn't even mean they're binge drinking. It's just that the link between alcohol and cancer is significant. 1 in 5 households living below the poverty level are led by an individual with an alcohol use disorder. And 30% of folks incarcerated in the state prison system are there because they were drunk when committing the crime that they are incarcerated for. So the harms related to alcohol are far more significant than just the fact that 1 in 10 Americans are addicted to alcohol use disorder. It is impacting our community at so many different levels, and yet we as a society are continue to think of it as something that should be involved in every celebration and in every celebration. I realize I'm coming close on time. There are 4 community-based solutions: place, controlling where and how, density of outlets, hours of sale. We know in Baltimore they turned back hours of sale from 2 in the morning to midnight in some neighborhoods and saw a precipitous drop in crime. Product, more and more we're seeing more and more we're seeing I'm so sorry. More and more we're seeing that alcohol is being put into containers, 3 or 4, a single container with 3 or 4 level of alcohol that's 3 or 4 times a normal beer container. Happy hours, gifts for purchase, display locations, promotion, advertising. The industry spends $5 billion a year that they write off on their taxes promoting alcohol consumption. And price. Most states have not raised the price of alcohol, the taxes on alcohol since Reagan was president. And Oregon is the only state with minimum unit pricing, which means there's a baseline amount of money. These are place, product, promotion, price. They're all community-based solutions that the alcohol industry is seriously preventing us from being able to address. With a single community action to regulate alcohol, we can simultaneously reduce poverty, cancer, opioid overdose, incarceration, suicide, and so many other things. It is a sort of one-stop shop, and yet at the federal level, we have no strategy for dealing with this crisis. We have seen the Center for Disease Control, all of their alcohol programs gutted within the last year. We saw the dietary guidelines put out by HHS watered down to the point that they don't mention underage drinking or the link to cancer anymore. We're seeing a retreat at a very time when we should be increasing efforts to better educate consumers about how their alcohol use impacts their families and their communities. If you want to learn more, please join us at the Alcohol Policy Conference this September. I apologize for the screwing up on the presentation here, and really look forward to your questions.
It was great, Mike. No worries. Technology is not our friend.
Yeah.
Holly, you're on mute.
Thank you, Mike, for taking giving us some community actions for people to take for this issue. I'll switch over to the next presenter. Dr. Velma McBride Murray is the Louis Audrey Betts Endowed Chair and a University Distinguished Professor for the Departments of Health Policy and Human and Organizational Development at Vanderbilt University. Dr. McBride Murray's research explores how context impacts the daily lives of African American families and youth. Her talk is titled From Surviving to Thriving: Translating Science into System-Level Change for Youth, Families, and Communities.
Good afternoon, and I'm really delighted to be here today. And thanks so much, Dr. Fishbein, for including me as part of this very esteemed panel. And so I'm going to be shifting gears a little bit today, really focusing a lot on how policies really do influence the creation and sustainment of systems, and that many of these policies are embedded in historical contexts with cascading effects and consequences for the conditions that families find themselves confronting raising healthy children. And these historical contexts results in persistent poverty, as both of my previous colleagues have talked about, the undersourcement of resources in these communities, which then leads to the problems of access to preventive intervention services and care. And these systemic conditions, unfortunately, have been influencing development and opportunities for people for generations. So what I'm going to talk to you today about is some of the work that we've been able to discover and fortunate enough to be invested in that really shows how valuable community members are in the process of addressing the issues that we've been discussing thus far. One of the ways in which I try to explain the world is to develop what we call heuristic or conceptual models. And this is a model that we published in 2018 that really shows how these structural conditions, oftentimes called social drivers or social determinants of health, we represented them in this model as mundane extreme environmental stressors. And you can see that there are a lot of the systems that have direct impact on the lives of families. Many times people say, why are you including a model that really looks at historical context? And it's because historical context really do set up for what is currently going on in the lives of these families, creating the kinds of experiences that they are going to experience as a consequence of these structural oppressive policies. And they have also set up positions, as I was telling a group of individuals the other day, the mere fact that we use marginalized populations and disadvantaged populations, their social positions that have really been a consequence of this historical context. So I'll be talking a lot more today about these protective processes that are used not only to raise healthy children and be healthy and to help kids avoid risky behaviors, but they're also used to navigate these structural systems that impact the families. And I want to emphasize that families are not the problem to fix, but they are partners and should be in preventive interventions. I want to illustrate how important these structural stresses are in the life of the kinds of concerns that families have raising their children. And you can see from this particular slide that young people are experiencing enormous amount of social stressors, social inequities, including racial discrimination, and their families raising them in persistent poverty has been linked to a sundry of problems that these children experience. Mental health problems, internalizing, externalizing problems, including relying on substance use as a maladaptive way of coping with the kind of situation that they've experienced. And I think pictures share 1,000 words, and nothing can be more telling than these headlines that really demonstrate what it's like for many of these parents raising children in these environments. what we've tried to do, and again, in another model, is to show how these community level processes are really protected spaces for families in order for them to raise healthy children. So we developed this multi-level community resistance and resilience model. And I say resistance because some of these families are actually engaging in processes to try and stop these oppressive downstream systems from impacting their communities. And when they do that, it really enhances the family's capacity to engage in what we call positive parenting, including monitoring their children and engaging them in socialization practices to be able to navigate these hostile environments. It then filters into the life of these individual children that then reduce the likelihood that they're going to engage in risky behaviors. I attempted to illustrate this by this, we call it the rubber suit. And the rubber suit indicators, you can notice that there are several community level factors that families draw on. And I call this rubber suit as a way of families protecting their children in order for them to navigate these situations where they find themselves in places where they don't feel necessarily comfortable because of the experiences that they're having in these oppressive settings. But kinship support is a major part of these families' protective processes, as well as other adults in the community helping these families as they're raising their children. This particular model illustrates ways in which we really do implement the work that we do in communities as partners. All of the work that I have done over the past 3 decades really results in partnering with the community in order for them to understand what we have been finding out about them in these longitudinal studies. These processes then have influenced how we go about really conducting research. They help us understand even these sophisticated models that we develop. They're not only from our research studies, but they also come from the experiences of our community, helping us understand the extent to which what we're thinking about in terms of studying these families really map onto their lived experiences. In all of our work, we also rely on the community to help us understand how to actually conduct research studies as well as preventive intervention trials in the communities in which we're testing preventive intervention programs. We are now also engaging them in our efforts to look at dissemination and implementation. And all of it then leads back to our own research studies, but you can see that they are a very integral part of the way that we do our work. So why does partnering with communities matter? They matter because it shifts the blame from really having them responsible for what's happening to them to looking at ways in which they explain why their situation is the way that it is. It also centers the strengths of the community and the work that we actually want to understand about them, because understanding ways in which their strengths can be leveraged also allows us to be able to then design preventive interventions that reflect their lived experiences. And we also know that just taking programs off the shelf and then giving them to families when they in fact have not been tested on these families results in the programs not being as effective. So they help us create culturally and contextually usable programs as well. And so I'll now talk with you about how we have then leveraged our partnership with the community to translate research findings from a 25+ year longitudinal study, really documenting not only the risks that these families are experiencing, but the ways in which these families are navigating their stressful situation. And the 2 programs that I'll specifically talk about today is the Strong African American Families Program and the Pathways for African American Success. The Strong African American Families Program was tested several years ago with 10 and 14-year-old kids, and it was in 7 different sessions where the family we drew on these strength-based cultural assets and designed these programs. The second generation program was a Pathways for African American Success program that included 5 sessions, but we expanded the delivery platform such that this particular program is available in 3 different delivery platforms. This is what we target. The things that you see in green are those promotive parenting processes, and then those processes we conjectured would promote real life skills for these youth, and having these real life skills in these youth would result in stronger executive functioning and civic engagement, and long term it would reduce engagement in risky behaviors, substance use, as well as other health compromising behaviors, improve career options, and reduce other kinds of negative outcomes, as well as improve positive relationships. So our evidence shows several wonderful things that I want to share with you now. One, we track these young people from age 10 to 14 to age 26. We show long-term reduction in substance use and all of the other outcomes that you see there, as well as increased resilience, resistance, and critical consciousness. All of this happened as a consequence of engaging the community and co-creating the programs that I just mentioned to you. These are culturally relevant preventive intervention programs, and they work because they were co-created by families and communities. So focusing on community systems also matter. When you focus on community systems and you engage them in the process of designing preventive intervention programs as well as designing research studies, the community they gain the trust that you are going to really do with their data what's going to be useful for them, because many of these communities have been exploited from not only the research studies, but they have also been exploited in terms of how people have gone into these communities delivering preventive intervention programs and creating harm. It also requires having local partnerships, and it's investing in these communities. We can't helicopter in, get what we need, and leave. It requires really an investment and a bona fide investment. Working with and through the systems that the families rely on and are central spaces and places in these communities, schools, faith-based organizations. Also finding ways, and particularly in these medical desert places, how we might be able to leverage the voices of these communities, because I'm in an area where we're losing lots of rural hospitals. There are no mental health service delivery programs in many of these counties, but finding a way in which we can help community members become mobilized as a way of finding ways to develop sustainable structures in order to be able to help their families. We need rapid dissemination strategies as well. Many of us, particularly academicians, we've published a lot of our work in research journals. We need to find a way to move information that matters in these communities beyond research journals, working and partnering with them because they have some great ideas about ways in which we may be able to effectively reach members of their communities. Investing in family-based preventive interventions, we have found in our work, will have long-term benefits. Not only does it have long-term benefits, but it does it by having strength-based, family-centered intervention helps strengthen protective parenting. It helps promote academic engagement. Kids that are engaged in school and have future orientation are less likely to be kids that are going to rely on substance use or other health compromising behaviors in order to be able to prove that they are worthy. And there's a need also for, we're going to have an uptake in these programs that have been already created, it's important to look at the extent to which we have, what the programs that we have, are they really culturally relevant? Do they include community voices? Does it have sustainable implementation strategy? My colleague, Dr. Gales mentioned earlier, developing an infrastructure requires more than just having programs, but what do you need in order for the programs to be delivered and to be scaled up in these communities? So policy implications might include things like, as been said earlier, invest in the infrastructure. I was part of the consensus report in the National Academies that wrote this blueprint for creating an infrastructure to sustain preventive interventions. And so I know how important it is. And this actually is a wonderful resource that I would encourage each of you to get a copy of, because it lays clearly out the specific recommendations and who should be responsible for helping us build this infrastructure. It's also important to invest in family, parenting, youth-centered preventive interventions. Implementation science is another area where there needs to be great investment, because knowing how to deliver these programs and sustain them in real-world settings is important, and we need to study them, and we need to support grants that allow community members to take these programs and test them, as a diffusion of innovation theory would suggest. Try them out and determine what needs to be adapted in order for them to scale up. To do that, we need a workforce development. We need research partnership investments as well. The big lesson is equity plus evidence is going to be impacted, is going to create impact. Having these programs, structures, resources, opportunities for all youth is what's going to be important. We can improve and reduce substance use among youth when we address those structural inequalities that may be creating circumstances in communities and families that's stressing them out to the point that this may be a reliance as a way of medicating and coping with negative life events. Strengthening families, investing in the community systems, including providing resources for faith-based organization, youth serving organizations that's there, a viable system in communities where we can begin to provide services for children. Prepare the workforce, which includes partnering with community partners and training them as program implementers, including health service delivery people, and delivering grounded preventive interventions. The most effective solutions are those that communities help create, trust, and sustain. As they would say, nothing with us, nothing for us without us. Thank you.
Thank you, Dr. McMybury, on showing us how to mobilize sustainable community-based prevention programs by working with and through those spaces and places the communities already work in. Next up, we have Dr. Rachel Winograd. She is a licensed clinical psychologist, an associate professor and director of the addiction science at the University of Missouri St. Louis. Dr. Winograd's work, spanning clinical care, research, program development, and advocacy, includes identifying and reducing barriers to evidence-based treatments for substance use disorders and expanding access to prevention, treatment, and recovery support services across St. Louis, Missouri, and beyond. Dr. Winograd's title is Start with Science, then Study What Sticks. Thank you.
Thanks, Holly. Can you enable my video?
That should do it.
Okay, great. Thank you. Hi, everyone. Thanks so much for having me. I appreciate the presenters who I am following, and I think they've teed me up nicely, especially Dr. Murray just previously. We've done a lot of discussion about program development and implementation. I'm going to talk a little bit more specifically about community engaged research. So we all agree, I think, if we're here, that community-based research is relevant and community research should be done in partnership with community members and providers. And yet, in reality, that's much easier said than done. Very often, community partners don't trust academic institutions. They've been harmed in the past. They don't directly experience the benefit of empirical studies that get published in papers that they probably can't even read because they're behind a paywall. But most importantly and most directly relevant, they are already very busy serving the people in front of them. So the idea that they would drop what they're doing to partner on a grant proposal that's due in 3 weeks with an academic they've never met is a total non-starter. So we can talk as much as we want about community engaged research, but unless we have existing relationships, those are very unlikely to take off. So herein brings the premise of our addiction science team and Aspire Lab here in St. Louis, Missouri, at the University of Missouri St. Louis.
We have our broad addiction science team full of all sorts of wonderful people developing and implementing programs across the state and helping evaluate them, as well as our graduate lab in the clinical psychology area, ideally to layer aspects of rigorous research on top of program implementation that's already in action across the state. So we operate with this bi-directional, never-ending feedback loop on the premise that community practice, what's happening out there, should directly help us identify what's needed in terms of the research lens and program and funding and advocacy. And then that research should inform community practice to help us continue to do better and make quality improvements as we go. And our team here in St. Louis is uniquely positioned to do just that. So while many academic teams are solely academic teams doing evaluation and research, and many implementation programs are solely implementation, developing services and programs and putting them out in the streets, we try to do all of that under one roof, which, as I say often with my team, is what makes us so special and unique, and also makes us often want to tear our hair out. But we start essentially going from left to right with 4 functions of our team. We distribute supplies across the state of Missouri, namely naloxone products, but not just that, other tangible goods to meet immediate needs of the organizations with whom we partner. We also build education and capacity through training and relationships and technical assistance. We continue to interact with partners to see what's working, what's not, and help get that message out there quickly through webinars, toolkits, reports. And then we also have a function of in-depth research and analysis to look at data from a big picture statewide perspective and qualitative and quantitative in nature to find meaning and look at trends and patterns. So I'm going to highlight 2 quick examples from our work over the years that where we've touched on each aspect along this spectrum to make real advances. So the first is our broad portfolio of first responder programming. So we started with giving, and that's sort of the theme here that I'm imparting. We started being the statewide hub for naloxone, where we offered a ton of free naloxone, the opioid overdose antidote, which is something that these organizations needed. Sure, a lot of ambulances already had it automatically, but fire departments didn't, police didn't, a lot of volunteer first responder groups across the state didn't. So we filled a need for them, both to help them do their jobs and save lives. We coupled that with training that was co-led by first responders who we paid an hourly wage to help us deliver our trainings. We also found out to get them post credits, a continuing education thing that they need to do their jobs that made our trainings attractive. We developed leave behind naloxone kits for them to leave at the scene with loved ones, helped develop protocols and partnerships to connect people with post-overdose care linkage programs, with peer navigators, but also with buprenorphine facilitated by paramedics in the streets. Most recently, we've given out xylazine-related wound care kits in response to their concerns that they were interacting with patients with these gnarly wounds and they had nothing to offer. So we started by giving to help them meet their immediate needs. And then over the years, a lot of organic research opportunities evolved, and we were perfectly positioned to say, hey, we already know you. We're already in relationship. Do you want to go in on this workshop with us and help us deliver it? Do you want to help us write this manuscript and offer your insights from the ground? Do you want to partner on this grant proposal? Yeah, it's due in 3 weeks, but because we already know each other so well, that trust was already built, and they were able to respond and turn it around, knowing that, like, hey, this is a bi-directional mutual relationship. Here are some snapshots of the implementation work and the research work that we've done with first responders across the state. A little identifying quote in the bottom right about how helpful they find our trainings in terms of practical applicability on the scene. The second case example I want to highlight is related to recovery housing and medications for opiate use disorder, specifically methadone and buprenorphine and naltrexone. Methadone and buprenorphine in particular are gold standard for opiate use disorder treatments, so they reduce deaths, overdose deaths by over 50%, and yet they're way underutilized, facing a huge amount of attitudinal stigma and logistical and capacity barriers. We've tried to make inroads to expand access to MOUD across the state for the last decade, And where we've been most successful is, again, where we adopt this practice where we start by giving. A lot of these organizations need that naloxone already. They want and are interested in training, like trainings that are also co-led by people from their same field and profession. They have asked for bus passes to help the people they serve get around, wound care and withdrawal care kits to ease suffering, medication lock boxes. We identified that was a real barrier because one of our partners sent me an email saying, "Hey, this is crazy. I can't get people into a methadone clinic unless they already have a lockbox. Can you help me find out how to make that happen?" So here we are. And then most recently, we've also issued small subcontracts to many recovery housing providers to help us pack naloxone because we don't have enough hands. They need the money and they want something to do with their hands. It's a match made in heaven. Eventual research opportunities that have arisen similarly to our first responder programs. They've helped us co-design measures of MOUD barriers that are most relevant and salient to their environments. They're currently engaging in qualitative interviewing and helping us recruit for our studies in respite houses across Missouri. And they also have been reliable turnaround partners for grant proposals that have popped up over the years because we have that existing relationship. Here are some snapshots of our work in the MOUD space with recovery housing providers and others. But you can see here we are out and about doing everything from meeting transportation and medication lockbox needs to putting Post-its on walls to trying to get their insights in a creative brainstorming fashion. So if this approach sounds familiar, it's because it is. It's not new. It's harm reduction. So this is how harm reduction service providers have operated day to day for decades. They start with giving. Hey, you need sterile syringes? Hey, you need naloxone? Hey, you need a sandwich? You need a hot cup of coffee? What do you need? I got you. Then over time, those relationships are built, that trust is formed, and we know from decades of data that people who engage with harm reduction services are more likely to engage with other medical and health and well-being services, more likely to enter treatment. That is not something you can mandate someone do when they don't know you from Adam and they don't know who you represent or what your motives are. So we are trying to do harm reduction at an organizational level. We meet organizations where they're at, foster bidirectional mutual relationships, trying to counter the exploitative history that so many academic and medical institutions and teams, have maybe been well-intentioned, but pioneered behind us thinking, of course this organization would want to be a part of our study. Of course they'd want to be part of our grant. And that's just not how it works day to day. We have to actually meet people where they are and organizations where they are if we want to develop true partnerships in the long term, research and otherwise. So thanks to the team and our funders. That's all I got for me.
Thank you, Dr. Winograd, for showing us a little bit into the work that you're doing with harm reduction programs. So the next presenter that we have is Liliana Lily Miranda. She is a community health worker and a Master of Public Administration student at the University of New Mexico. She serves as the program coordinator for the UNM Collegiate Recovery Center. Her work focuses on bridging community-informed approaches with evidence-based strategies to strengthen prevention, improve engagement, and ensure recovery support systems are accessible, culturally responsive, and sustainable. Lily's talk is titled Strengthening Prevention. Lily's title is Rooted in Community, Why Connection Matters, and for Prevention and Recovery.
I got scared a little there. I was like, oh my
Sorry.
God, did I give them the wrong presentation? Oh no, just kidding. So, hola todos. Hi, everyone. Thank you for the wonderful introduction, or because it's about me. Just kidding. So like I was introduced, I'm a community health worker, certified family peer support worker. I'm a program coordinator here, well, the program coordinator for the University of New Mexico Collegiate Recovery Center. And I'm also a person in long-term recovery. And so my presentation is going to focus on taking everything that these amazing researchers and all these projects that were presented by the presenters, what they look like in real life. I'm going to be sharing from a lived experience perspective, and also what it looks like to be working community-based, and where we support students, family, researchers, and organizations across New Mexico. And in case you don't know where New Mexico is, we are the forgotten middle child between Arizona and Texas. We'll leave it there. And so for me, community engagement is really a lot more than just a simple strategy for prevention and recovery. This is actually one of the most powerful tools that we have in creating really healthy communities. And so I want to start with a really simple idea that has really shifted and shaped a lot of the work that I do. And that is that substance use doesn't start, getting ahead of myself. Substance use doesn't start in a crisis. It really begins a lot longer before that. And so when we start looking, as the research has been shown, we start being reactive versus being proactive. And this prevention comes into play when people really start feeling connected. And like the slide says, this begins, substance use really begins in moments where people just don't feel like they have the support, information, or the connection that they need. It really begins when people start feeling isolated. They don't know where to turn. Importantly, they don't see themselves reflected in the systems around them. And sometimes prevention isn't a program. Sometimes it's just a trusted adult who listens, a peer support worker who understands, a family member that says, hey, I noticed that you're not participating as much, or even a community that says, come hang out with us. We're doing this fun things. And those small moments really do make a difference. And so I'm going to talk a little bit about myself. I am a person in long-term recovery. July 5th, I will have 10 years since I checked myself into rehab and decided, I needed to get support. And so I'm a first generation Latina. My parents came here early 1980s, late 70s, which is the picture of the oldie picture on the slide. And so I did not grow up speaking English. Spanish is my first language, and I learned English when I was 8 years old, 8 years old. I learned it in school. And so, going into treatment, addressing my substance use really shifted how I see this field and what community work looks like. I had to take the initiative in looking for a treatment center, looking for a place where I can, check myself in. And my mom came with me, and I had to translate everything for her into Spanish. And so I've used this as an opportunity to expand my career, and use this as an opportunity to show how important language, culture, and access are important to the work that we want to do. I've worked in so many different capacities in helping build community voices into research and public health, and connecting students and families to support. I'm like, next slide, but I'm the one doing the slides. Anyways, so I want us to take a step back and really look at this picture, and I picked it on purpose. I think we all can relate to being that lone person and in a room full of people, right? Like, I think we've all felt that. This is our mascot, Lobo Louie. And I remember feeling this exact way about 8 years ago when I stepped onto the campus of the University of New Mexico. I was an older student. I was about 2 years into my recovery, and a lot of the activities that were being offered to the undergrads really centered around alcohol. And I really wasn't feeling that connection of being part of, being proud that, I'm returning to school. And so with the opportunity to start the Collegiate Recovery Center here in New Mexico was presented to me, I really drew on this experience. I really wanted to make sure that it wasn't just a place where students can come and get resources for, their crisis. It's more of, how do we start this connection? How can they speak to someone who understands them? Someone who will make them feel welcome, who looks like them. If you don't know, UNM, the University of New Mexico, is a Hispanic serving institution. So the majority of our students are of Hispanic Latino descent. And so I wanted to make sure that they were represented not just in the photos that I use into our marketing stuff, our flyers, but also it was in Spanish. I translate everything into Spanish, and I also use a lot of my cultural practices into making an environment where people feel supported. And that means I will talk to them in Spanish. I will curse. I try and be as relatable and as authentic to myself as possible, where these students don't have to feel like they're coming when they're in crisis, but instead they're coming to find connection, to find someone who understands them. And so this, we had this whole presentation, was it 4 presentations talking about the amazing research and the work that is being done in other universities and around the country. And so I'm not going to get too much into this. But we all know, connection is a protective factor. Connection really helps reduce the risk of people participating in maladaptive behaviors. Community engagement really does improve outcomes. And we see that with a lot of these research and these presentations that have been shown, which is amazing work. And so why does access matter? This means so much, not just for students, but also families. When people feel like they can access someone that they have a connection with, that the possibilities of them, engaging in that work really elevate. Go up. I can't think of the word. Sorry. I thought about it in Spanish. But anyways, so one of the important things that I learned is that when we expand Spanish language access, it's not only the language that we are expanding on, but we're also expanding on the trust that people will have. And the trust that we have in being the experts in helping people really goes a long way. I think a lot of us have seen that who work in the field, understand that, right? Like, not everyone will say, like, I'm going to check myself into treatment and let's see what happens, right? Like, people do their research, they understand we have access to the internet. And so we want to know that they are going to really see us as people. And that includes our culture, our language, and our practices. And so when we have access, a lot of people feel seen, heard, valued, connected. And that is so important when we're creating genuine partnerships with communities. Dr. Murray said, nothing about us without us. I'm a firm believer in that. Like, why are we doing research papers or research projects and community members are not involved? Like, did we ask them if they wanted that? And so with trust, it also creates opportunities for prevention. And so when we start looking at who is getting recovery services, we start to really start thinking about this slide. I'll take a minute for you guys all to read. And it says, addiction does not discriminate. Recovery often does. And I'm pretty sure some of you are really uncomfortable about it. And I will tell you, I love using this phrase because it's so, so true. Access is really shaped by language. Do you offer services in Spanish, which Latinos or Spanish speaking community is one of the fastest growing communities in the United States? Do you offer other services that are culturally responsive? Culture is really important. People really want to know that you're taking them into consideration. Are there holidays? Are there different foods that you can offer? Geography, right? Right now, we're seeing how a lot of the rural communities don't have access to services. Well, I mean, we have addiction, but do they have recovery services? That's a form of discrimination there. Transportation, resources, right? Financial resources. We saw in one of the presentations how the social determinants of health really do affect how a person accesses these resources and recovery services. So, we are seeing more and more how a lot of this federal investment really does matter. We want to build these partnerships. We want to build this infrastructure. We want to build this connection that we need. But yet, who's doing the work? We can't pay our mortgage. We can't pay rent with, thoughts and prayers. We need action and we need to get paid also. And we also have to make sure that we're strengthening local partnerships. We're improving access to services. And this takes a lot of like physical labor, it takes mental labor, and it also takes a lot of financial resources. And so when a lot of these funding sources are preventing us from being able to really adapt these services to the communities that we work in, it really does emphasize more that recovery does discriminate. And it's a really sad truth to really come to terms with. And so when we really start taking a look back at how community is prevention, it really makes us look at how substance use does not begin in crisis. It really does. It doesn't. It begins in moments where people lack connection, support, information. And so when communities are given the information, are empowered to really support each other, we create trusted adults. We create supportive peers. We create culturally responsive programs. We create resources that people feel like they were done specifically for their community. And so when we have community partnerships, these are all preventative strategies. We saw all the research that our other presenters really showed and how it is really, really essential in creating this community connection. I know we were short on time, and so I sped through. And so these are my references because I'm a grad student, and of course, I have to have that. And so, yeah, so I wanted to share a little bit about that. I'm with the Collegiate Recovery Center at the University of New Mexico. And I thank you all for sticking around and listening to all these amazing presentations. Thank you for having me.
Thank you, Lily, for showing us that access matters in every aspect of the term, and that one small moment of connection can really make the biggest difference for someone who really needs to feel seen, heard, and at least feel free to ask for community help.
Yeah, that was great. Everybody had remarkable presentations, really informative, and I think enlightening for many of the participants in that we don't always think of it this way. Especially researchers, right? We just do our research and we don't necessarily think about how community needs must be involved in order for anything to make a meaningful difference. We certainly don't want to impose our own biases that might be implicit in ourselves on those that we're trying to benefit. So I thought that came across in all of your presentations. So go ahead, Holly, you have a couple questions for people.
Yeah. So some of the questions, there were a few questions in the chat. Most of them were actionable questions. So they want to know if we can share these slides and presentations with other communities. And they specifically, one of them for Dr. Winograd was, so you mentioned the two programs for harm reduction. How can people expand those prevention programs? How can they do it in their own communities, and can they reach out to you for those?
Okay, well, I did see, I'm not sure about your question, Holly, but I saw a question in the Q&A that I responded to directly, but I'm going to say it again here. One was asking about our first responder trainings and if we offer trainings for other audiences. The answer is absolutely. I'm going to put a link to our main training page here in the chat, where we have public trainings that anyone can pop into, and we're also able to cater to your agency or organization. But for this other question that's in the Q&A that specifically asks, how did you initially get the money to give away what people need? Good question, Anonymous. We are a sort of well, a lot of it is luck or combination of right place, right time. Um, I got hired here at the Missouri Institute of Mental Health right at the time when opioid-related funding was first getting going about a decade ago. And we have really good relationships with Missouri state agencies. So in your state, who is the single state agency, the SSA, that is the default recipient of SAMHSA and other behavioral health funds, often opioid settlement funds too, others? They typically work, depending on the state, with like a handful or a dozen of like close contracted partners to be their extended workforce. And they don't really give a crap usually about research. It starts with like, who can help us do this service and training and implementation work? And so we made ourselves appealing and attractive to do that. And then they, when we're like, hey, but this really needs to be studied and evaluated, can we do that too? Then we sort of built on that relationship as well. So we got in for SAMHSA funding and opioid settlement funding with our state agencies to answer that question.
Thank you. The next question in the chat was for Mike. So the person is asking, how do you make the causal link between new cancer diagnosis and alcohol consumption? I don't know if you want to take a stab at that one.
Yeah, it's a little bit over my pay grade in the context of the science of this, but I think that if you go to the website for the National Cancer Institute or the National Cancer Society, you'll see that there's all kinds of appropriate research making that link. It is a challenge, and we've looked at litigating on this issue, just like tobacco did relative to addiction issues and people having lung disease as a direct consequence of their smoking. And there's definitely more research that needs to occur, but smarter folks than I feel confident in the data that that I presented to you.
Mike, do you want to mention the sequestered alcohol report?
I'm not sure. I know what you're referencing.
The alcohol report that was not released ultimately.
Oh, yes, that's an embargoed.
Embargoed, yes.
As people may have seen during the headlines around the dietary guidelines, there were two reports that were to be considered by HHS, but then Congress, in one of the appropriations bills, I think, said only one of the reports by the National Academy of Sciences could be, and the report created by ICPUD, and I'm blanking on the name of it, but it will be released a week from today. It was buried. HHS did not release it. There was a draft that had been released at one point, but it's going to be published next week, and makes it very clear of each additional amount of alcohol you intake increases the risk relative to developing cancer.
Thanks.
I had a question for both Dr. Gales and Dr. Murray. You both kind of mentioned you needing to start in the communities and keep that that research sustainable. But how do you, either one of you, believe that we can move from that helicopter research of like starting these programs and actually making them sustainable and community focused?
I'll let Dr. Gales and then I'll chime in.
Yeah, thanks, Wilma. So in the work that we've done, it's happened a couple different ways. So I'll just speak to kind of our experience. One was the first project that I talked about which was 6 communities across the country. It started first with some seed funding from a foundation. But what those communities did was also found match funding within their community. So what that means was they got the right people to the table. And so these community boards, these coalitions were not just people in the community, but they were also people that were tied to public systems. So they got public system investment. That really, I think, is the hallmark and the key for sustainability there, right? Because when that foundation funding was gone, they still had those public investments. And so it took those folks that were in industry, that were in state government, listening to those residents, looking at the data together, understanding what really is happening in their community that created true sustainment. The other way that we've seen this done has really been through research practice partnerships. And so I didn't really speak on this work in the presentation, but we've had a long-standing partnership with the Pennsylvania Commission on Crime and Delinquency here in Pennsylvania. And through that work, right, we do produce research that are policy questions, like policy directed questions that they're asking. But what it has generated over the years is a sustainable funding mechanism where they are funding community prevention. And that has evolved over time as we've learned from the practice and learned from communities what's working and what's not working. So I do think that there's a couple different ways for how we get to sustainability. And I also think that's still an empirical question today. So
Not much more to add except because that was well done, Jossie. The only thing that I'm thinking about is how important it is for the community facilitators. I was in a meeting the other day and someone said, don't call folks gatekeepers, but gate facilitators in communities. But to understand who they are and get their investment in whatever it is that you're doing. We can't assume that we can just go into communities and do the work. They really need to see that what we're doing is fitting the culture and ecological context of the residents in those communities. And there's no one size that fits all either. And that's why it's important to have them at the table. So whether the program is sustained or not, I think the first thing is to engage the community so that there is a platform and an avenue and a pathway by which programs can be in the communities and uptaken in those communities. But all the things that Dr. Gales mentioned earlier is on point. Yeah.
Mhm.
Okay. I know
Anything
we're
else,
running up
Holly?
on time. Yeah.
Yeah, we're at 3:30. Did anybody have anything else burning?
I just want to mention, Lily, it just touched my heart. So your presentation, it was just absolutely incredible. And I just want to thank both you and Mike for being a part of this because in our academic world, we use a lot of academic jargon, but the ultimate goal is to be able to hear the narratives of individuals who actually understand how to use what we do on the grounds. And I appreciate being on the panel with you.
I echo that. Thank you, Velma.
Yeah, and also I'll say, we've got this kind of sandwich between policy and lived experience and how things play out in communities and sort of trying to draw a full spectrum of connections that need to be really nurtured in order for any of this to work. Right? For policy to work, you have to have community engagement. You have to have community engagement in doing the research that directs us with respect to what works best. It might not work best in some communities than others. And so they all need to inform one another. It needs to be part of a really interconnected system of communication.
Takes a village.
Yes, a national village. Yes.
National village,
Maybe international.
yeah. Yes, because there's some international folks on. I saw earlier someone from
Yeah.
Kenya. Yeah,
Yeah, we get a wide audience. So
this is
yeah,
great.
thank you. Thank you all.
Thank
This
you
was
for inviting
really
us.
terrific. And just for those that are still here, don't forget about our September 16th. I said 15th, our next September 16th briefing on a whole of society approach. So take care, everybody. Peace.
Thank you, Denny.
Thank you. Thank you, Mike, everybody. So appreciated.